a focus area that has the longest title in CMS history. Just kidding, but it's called Forming Communities of Practice to Improve Patient Safety and Reduce Harm. So I'm Elena Balablankov. I'm the Quality Improvement Director for Network 2, and I'm joined by Megan Paris, who is the Quality Improvement Coordinator for Network 1. In developing this presentation, we worked really closely together because this is work that we're passionate about, and we wanted to be sure that we came up with some ideas that you can build on to help us share CMS's vision for this initiative. Next slide. So just a couple of silly housekeeping things. As we said, the call is recorded. Your lines are open to ask questions. Please don't hesitate to ask a question. You can also put something in chat. I will be calling on several of you to talk about what's going on in your clinic. So I want to thank you ahead of time for agreeing to do that. Next slide, please. So when you're not talking, since we are recording this, if you could please mute your phone when you're not talking. And again, you can use the chat feature. You seem to have good volume. Most everyone that I spoke to, we have good sound. So I think that we'll be good. And then remember to do what I always forget to do is unmute your mic when you're asking a question. Next slide, please. So I know all of you guys are wondering, even though I've spoken to each one of you individually, is why are we doing this? How did I get selected? What is the life cycle of this project? And am I required to be here? So let's take it one by one. IPRO was awarded a 5-year contract in June of this year. And the statement of work outlined numerous focus areas for improving quality outcomes for patients with end-stage renal disease. There are actually 7 topic areas that are being worked on through the networks, through the facilities across the entire United States, so that there are other places that are doing the same work as you will be doing. So with the focus on improving the quality of care for patients living in nursing homes who are on dialysis, whether you're getting your dialysis on campus or whether you're traveling to the community, what's happening is that we're looking at the care that people are getting. And so 25% of you have been selected from the state of New York to be the first ones to participate. And eventually, every 4 months, and you'll hear about it further on, we will be doing this with all the clinics. Each time we're going to continue to add a group of individuals and work through this work together. The life cycle is this. So you'll be an intensive group for 4 months, and then you'll step back and still be our participant, but not within the focus of intensive outreach. And am I required to participate? Yes, as I asked you all earlier today, that I want us to work together. I'll do whatever I can do to help you all be successful. But CMS is incredibly wedded to this work, as is IPRO, and it's something that we really do believe in. So we're going to try to make it as easy and as interesting for you all as possible. So I want to be sure that you know that, again, I'm only a phone call or an email away. I've talked to most of you, over the past 2 weeks. So let's get started talking about what the work is and where we're going. Next slide, please. So just so you know, IPRO is big. We have, as you can see, across the United States, we cover 13 states. We have 4 networks, and we're involved in greater than 130,000 patients. And when you think about that, that's a lot of patients to impact care on. And in addition to that, we have about 2,000 facilities, and we don't just focus on kidney disease, we also focus on transplant as a modality of care. So these are all activities that are supported by CMS through the work with the networks. Next slide, please. So how did this model come up? The idea is that nobody can do this alone. So as I said, we got the contract for 5 years with multiple focus areas. And you can see them on here, focus on vaccinations, which makes sense to everybody with what's going on COVID, reducing hospitalizations. We're the nursing home group, patient family engagement, and we could go around the circle.
So your first name and last name?
Is someone asking a question? Hello? Okay, if you're not speaking, could you mute, please? Thank you. So the structure of the work is based on this. What happens is that we have gotten together what is called an advisory committee that is grouped on, how can I say this? Probably national and local leaders, experts in kidney care, people like yourselves, physicians, stakeholders, members from LDOs. And what happens is that we have built kind of like a brain trust. So these individuals will help drive the work by developing interventions that include best practices, developing practice guidelines, identifying problem areas that you all will bring to us so that we can share with the group and try to find solutions, actually. And that large group is called the advisory committee. Next to them, as you can see on the circle going around, is the community of practice. And the community of practice is what we are. It's you, me, the network, people that you will involve from your clinic, your PCTs, your patients, your caregivers. And so what happens, the advisory committee in the center helps drive the work so that you don't have to reinvent the wheel. We'll be getting information and we can share from everybody. And so we'll talk about things that people are doing really well on, that you want to brag about, that we can share with everybody. We're going to be honest about what our struggles are and what we need help with. Because if you've encountered it, trust me, someone else has as well. And what this does is, if you look at it, this is called the snowflake model. So that basically we're all learning from each other. We start from the center. It grows, it has a middle, it has different arms, and each one is unique, just as what happens in your clinic is unique. Next slide, please. So this gives you a little bit more information about the advisory committee. So basically, we interact with the advisory committee. They help us in growing this community of practice by sharing ideas, analyzing data, and we'll talk about data in a minute, that then we can take and use to formulate ideas for activities. With data, the thing that's important is, and we'll talk about it, is the fact that there's a difference between self-reported data and what's called vetted data, and we'll go over that. But some of you mentioned to me, well, you know, I'm not sure what data I'm supposed to turn in, and we'll talk about that. So the data that is self-reported is just as important as data that is vetted through CMS, like claims data, EQRS data, NHSN data, NCC data. And so while the data that we have right now is currently limited, your reporting of improvement, even by one person, two people, whatever, is demonstrated growth, and it's important, and we're going to celebrate it together. Next slide, please. So let's talk about what this will be. We have what's called a life cycle on the Community Coalition. So basically what this is an outline of what the work is going to look like. The first phase is what we're going through right now. It's us talking, sharing emails, collecting information through the root cause analysis, looking through that and seeing what problem areas you identified, your focus areas. We're going to look and see what best practices you have, because some of you were fortunate enough to be able to say, gosh, our infection rate is really low. Do we still need to do this? You know, how can we help? You know, what are we going to be able to change? And, you know, that's what we talk about, sharing best practices. And then what happens is we're going to spread those best practices, and we'll continue to share ideas and build this ongoing work until we actually go across the entire state of New York. So that while you're the first group, you're definitely not the last, and this is what we call a community of practice. Next slide, please. So these are some of the things that we've done or are doing. So we're doing the RCA, and we're identifying barriers to improvement. That's month one, that's September. And I wanted to ask a couple people, because I know some of you have had the opportunity to do your root cause analysis, and some of you have not, and I've talked with some of you that are struggling with it. Is anybody willing to share, those who haven't done it, what kind of problems you're running into in terms of pulling the RCA together and looking at the barriers that we're going to work on over this 4-month period? Can somebody volunteer? Andrea, Annette, Salil, any ideas for me?
Question, Helena? Sorry.
So Salil, how is it for you doing this root cause analysis for your clinic to identify what you want to improve on about infections in long-term catheters, peritonitis, or reducing the transfusion of blood for patients that are treated?
So, the root cause analysis, I just put like other, basically the communication between the nursing home and the dialysis facility. As patient safety consideration, we don't get that much information from the nursing homes. The patient fall there, patient have anything, they didn't get medication, no communication. So that's the best thing, we are planning to improve, we create a template like a nursing home communication sheet. We send, what's anything happens in the dialysis clinic, we inform them. So, but we didn't get that much support from them, especially from nursing homes. That's the hard part.
And I think that what you bring up is really important when we talk about it, performing the RCA, that while you may not have, my focus is on communication, because communication will improve all of these activities that you identify, the problem areas for reducing infection, because knowing what's going on with the patient when they're not with you is incredibly important. And part of that you're doing for your RCA will also go as part of your plan, do, study, act process, because as you say, you have communication tools that you check with the clinic what's going on when you receive the patient, when you send the patient back. You also check with the nursing home. What did the patient look like before they came to you? Did they have any problem areas? And those are the things that we're going to be looking at month 1 through 4, is, planning an activity, doing an activity, deciding, did it work? Do we keep it? Do we abandon it because it's not helping anybody? And so then after that 4 months, this group of 25% will step back. You'll still be part of it. We'll still be collecting ideas. We'll still be sending you interventions, but you no longer will be part of an intensive focus. We'll check in to make sure that everything's moving forward, that there's no backsliding. And so what happens is over time that these challenges become less challenges, and again, they become successes. Next slide, please. So what this all comes down to is show me the numbers. How do I know where I stand in my work? How do I know that I'm improving? How will I know if I'm staying the same? So let's talk about the population we're working with and the data that we have. Next slide, please. So the biggest thing that we are focusing on is what's called the frail elderly population. And by that, we are not looking at a particular age group. Elderly, by definition of demographics, is considered over 75. Then you have what are called the senior elderly that are in their 80s. And then you have the one that you say, God bless you, I'm glad you're still here. But the idea is to look at patients that are elderly by age, also by our identification of things that are occurring in their life, in their body, in the way that they are receiving care, responding to care. We're looking at people who receive services in the nursing home. We're looking at all the facilities, as we said, across New York, rural areas, in the city, looking at people that may have an opiate disorder, a mental health diagnosis, could be anything from depression to bipolar. individuals who need anemia management. You know, that is huge for people with kidney disease. But the biggest thing is that we're not looking at just physical changes, we're also looking at cognitive changes. These patients have tremendous comorbidities. They have high risk of falls, they have loss of muscle tone, skeletal changes, osteoporosis, issues with coordination, and a lot of them are sad just because they're no longer in charge of a family, they're no longer running a company, they're no longer the foreman. And these changes, when combined with kidney disease, lead to anxiety, behavioral changes that some of us say, oh, well, they're a difficult patient, or they don't want to listen to me, or they may have outbursts. You may see changes in hygiene. A lot of Alzheimer's patients don't want to take baths, and which makes them at risk for skin breakdown. So all of these things are things that we're going to look at. And one of the biggest things is hopelessness. Is part of our job is to make the quality of life for a patient on dialysis, living in a nursing home, receiving care in a nursing home, leaving the nursing home, coming out of the community, that we are giving the best quality of life that we can possibly assist them with. Next slide, please. So don't panic. Don't focus on the fact that it says, oh my God, I have to decrease my catheter rate by 40%. Remember I said that this is a 5-year contract. So that is the 5-year goal, the one in the middle. What I want you to look at is the ones on the right that are your base goal. And it's based on your census. And we realize, and you all don't think about it, that fixing the quality of life for one person counts. Decreasing a transfusion on 2 people in your clinic over a year can be a lot, especially if you're a small clinic. So what we're looking at is why these seem like really overarching goals. You all have been working on reducing catheterism and bacteremia for years. This is another way to formalize the work. There are those of you who don't offer peritoneal dialysis. So, you know, that's not something that you're going to look at, but pretty much everybody has hemodialysis and patients that end up struggling with anemia that are on ESAs or end up getting blood. And if those are the 2 things that we work on, because that's what we see in our everyday life, we'll work on it together, we'll make it better. Next slide, please. So what are the ways that we can get data? Remember, most of our data is self-reported data, but I'm going to give you what I call the secret to the sauce. We do not have direct access to the nursing homes, so you are our conduit. But if I want to find out something about the nursing home where your clinic is located, I can look at Hospital Compare and see if that nursing home is a 1-star facility or a 5-star facility. If they're historically a 1-star facility over a couple of years, kind of gives me a hint that they might be struggling. If I look at their HCAHPS, that are assessments done by patients, and patients are giving them a low score when it says the staff spends enough time with me, the doctor answers my questions, that kind of gives me a hint that I need to keep an eye on what's happening in that facility. It also will tell me if it's a 5-star facility and if they're very highly rated, and how they're doing with the CMS measures, because they have clinical measures that they have to meet in order to be successful. We're going to look at the self-reported data that we were talking about that you all are using to fill out your RCA and ongoing tools that I'm going to send you guys. And then we'll also be getting data from the NCC. Right now, it doesn't exist, not relative to specific markers for nursing home, but it's coming. It may make it harder for you being the first group, and I apologize for that. But I also know that you guys are very good at reporting data. You did it during COVID. A lot of that data was self-reported. And over time, we got the tools that we needed to create process improvement. So we're just going to take our time and plug away at it 1 step at a time and go from there. Next slide, please. So I want to mention some of the RCA barriers that were collected, and I'm going to call on a couple of you to talk about some of the things that you have identified in your clinic that may be a barrier to reducing infections, and tied in with infections for catheters is also the idea of getting a catheter out. We all know that catheters are supposed to be a bridge. And what happens is, for a lot of times, that bridge goes a long way. 5 years down the road, that bridge is still there. So some of the things that you all reported was COVID had a huge impact, that people are getting discharged from the hospital really quickly. So there's delayed access placement. You didn't have surgeons that were performing elective surgeries. You couldn't get appointments. There were staffing shortages in clinics and in hospitals because of COVID. There were transportation issues. People didn't want to take patients that could possibly be at risk for COVID or may have COVID. And so what I'd like to see is find out what kind of barriers some of you guys are seeing that you would work on in order to drive down your infection rate for catheters and reduce transfusions or something along those lines. Andrew, and then I'm going to call on you if you don't mind.
Hello, can you hear me, Elena?
Yes, I can. Thank you.
Yes, hi. And so in regards to the vascular access and the long-term catheters, what we find in the dialysis setting that has a SNF that is affiliated with a nursing home is that there are several challenges. And one of the challenges is coordination of care as it relates to the vascular access appointments for patients who need to have a referral for permanent access placement, or who needs a referral for follow-up because of a vascular access issues. So I think that the communication with the nursing home is very important in terms of tying those issues together and to make it actually work. Because if the communication is not there to begin with, then you are
Right.
going to have an issue when you're trying to put these processes in place. What we have also found is that educating the nursing home staff regarding vascular access management is also very important, so that we can bring them into the loop as to what to expect. Why is it that we need to get the catheters out? And why is it that we need to make sure that we evaluate the permanent access so that we can mitigate the risk of premature failures? And so I think, again, the communication with the nursing home is very important, and educating the nursing home staff, I think we have found to be successful.
So that builds on basically the same thing that Salil was saying, that communication and being able to identify what's going on and sharing those challenges also help with, I guess, sharing solutions too, and trying to come up with things together. And I'm glad you mentioned education. We'll be talking about a new system that IPRO has set up to make it easier for people to educate each other in terms of using tools that we'll provide for you all that you can use for this initiative. I also heard from some of you that my clinic is a high performer, so now what? Marsha, are you on the phone?
Yes, ma'am.
So Marsha, can you talk a little bit about what we talked about yesterday in terms of your best practices for your infection rates?
Well, we have a bunch of different things we do. We have hand washing audits that we do to make sure that staff are washing their hands appropriately between patients and during catheter care. We audit to make sure the stations are being disinfected properly. We do, we have a specific policy and we educate the staff on it, and when they're new, as well as about quarterly, to make sure that the staff are following procedure properly.
And how is your infection rate?
Our infection rate is really low. I don't know what it is right off the top of my head, but we've had, I think, one infection so far this year. And that was not necessarily dialysis related, but we couldn't, it was an
Right.
iffy situation. So it's
And
extremely low.
sometimes I'm sorry.
It's extremely low.
Yeah, that sounds great. And sometimes you're right, we do have to take credit, for lack of a better word, when there's a question about an infection. So I'm glad that you brought that up, because that's also in data that we're reporting when we look at things going up and down in terms of our results. Next slide, please. So we're going to talk about the tools and interventions that we're going to use to fix some of the things we talked about and some that we haven't talked about yet, because we know how busy you are, not just looking at COVID, but looking at the frail elderly, people that are ill, trying to cover
Come on, Ben.
staffing, things like
Betty.
that.
Come on.
Sorry? So that the network, the NCC, and the advisory committee, we're going to be working together with you, and we're going to be taking the lead by providing you with tools and interventions that you can use for both your clinic staff, your patients, and your patient families. And what we're going to do is share things like Marsha's best practices, the ideas that we got about communication, and we will be taking these tools, sharing them with you, and getting your feedback. Next slide, please. So one of the things that we've pulled together is a patient safety toolkit. And so the one thing that we heard from our advisory committee, it's like, Elena, I don't care what education you and Meg do and what you guys come up with. It's got to be short, it's got to be directed, and it's got to be available at any time, because we don't have time to pull people off the floor for an hour for a lecture. And so we listened. One of the first things that we did is we recorded a WebEx on care of the frail elderly that you all will have access to. It's 17 minutes long. It's straight, it's to the point. It talks about assessment that nurses can do. It talks about review of systems that your unlicensed staff can do. We are giving you some toolkits from the forum for catheter reduction. We're giving you some stuff on how to talk about reducing infections, peritonitis, and also looking at reducing transfusions as part of your QAPI meeting and using what we call the QAPI 7. Take 7 minutes of your meeting in order to go over, what are the key things that CMS is saying that you need to look at your data and say, man, we had a good month. Look at what we did. And so we're trying to make this as easy for you as possible so that you can meet the goals, and also that it's not a rubber stamp activity, that you feel good about those goals as well. Next slide, please. This is another video that we have for you. This one is a little bit longer. It's about, I think, a little less than 30 minutes, but it's really good. And what it does is it talks about collaborative approaches when facilities work together to prevent infection, and how, as we mentioned with Salil, talked about communication, and that talked about communication. Marsha talked about communication. That is the key to all of this, along with audits and building in other tools. So, we want to make sure that you can be successful. Next slide, please. Now, this is where it gets tricky, and this is where you guys are our gold standard. I can't walk into a nursing home and say, hi, I'm from IPRO, and I got some really cool stuff for you to look at. But I know that I have really cool people working in my dialysis facilities, that if we put this information in an email and Provider Insider, if we put it on IPRO Learn, you can print it off, hand it to the person who's bringing the patient into your clinic and say, hey, this is something I want you to share with your manager, share with your team, share in your care plan meetings, because you all are taking care of dialysis patients. And you'll see different tools. Next slide, please. that not just communication tools, but how to check to see if a fistula is working, the look, listen, and feel. We're creating tools on what happens when a patient's dressing falls off on Tuesday and they're not scheduled for care till Thursday. So you will be our conduit to get information until we are able to build up the relationships and identify those contact people that we could work with directly. These tools are vetted. They're from the CDC, they're from ASN, they're from the forum. So all of these things are tools that we know work. They're short, sweet, to the point. They're one-pagers. They're plain language. They're very easy to understand. Next slide, please. So some of the interventions that we talked about, sharing best practices, community calls, and this is honestly is where we will be working with you all, because what will happen is, you remember my telling you that we are doing this work nationwide. So what I will be doing is practicing what's called bragging rights. The NCC calls on us to identify people that are doing really well, or they're people that are really struggling and could maybe learn something from some of the other people in the community that are doing this. And so you could be involved in a national call and a community call to talk about what's happening, because we think it's really important that some of the things that we're doing on the East Coast could be done in the West Coast, could be done in the Midwest. And you'll also be talking to each other as each community coalition moves forward. As I said, it happens every 4 months, so that they'll meet you, you'll meet them. You're going to be doing evaluations, because there is no sense us keeping tools that you say, Elena, this is laughable. It didn't help me at all. What my company has is better. Or if you say, gosh, I'm so glad you took this 5-page document and turned it into a 1-pager, and it works really well. And one of the things that I'm going to ask again for people to volunteer, we have to get together frequently. We have to know what's going on. So I can't help if I don't have contact. So what I want to know is just if a couple of you would give me an idea right now. Do you find that it would be better to do an open office where I would schedule something once a week, let's say on a Wednesday, or others that I'm working with at IPRO, that we say Wednesday from 10 to 11, you can call in. Got 10 minutes, you want me to answer your question, or you think it might take longer than 10 minutes, and you say, Elena, this tool makes no sense to me. Can you give me 20 minutes? Let's sit down and do it together. What do you guys think? Just in general, what do you think would be the best way for us to think about approaching this as we kick this off? Katie, what do you think? Katie, are you on mute? Andrew, what about you? What do you think? Are you all on mute? Meg, are we unmuted?
Yep, they can unmute themselves.
Okay. Do we have anything coming up in chat?
I don't see anything at this time, no.
Okay. Well, I want you guys to think about it, because my preference is office hours where you can get in and get out. You come in, talk about what you want to talk about, brag about what's going well. Let me know if you need a private meeting because you're struggling with something. But remember, we are only an email or a call away. And if you're working at something at 2 in the afternoon or 8 o'clock in the morning, we have an availability to make sure that you're successful, and that's important to us. So I'll be reaching out to you all so that you can tell me, how do you want to approach doing these interventions, doing your PDSA, finishing your RCA, so that we can be successful. We'll talk about things you can do in the clinic, like creating bulletin boards, sharing articles, sharing handouts. So let's move on to the next slide. But I do want it to be something you guys are thinking about. So we've talked about a couple things that we're doing currently in terms of audits, in terms of one-pagers, in terms of communication tools. Does anyone have anything else that they can mention that you think is really good that you can share with Meg and myself that we can see about sharing with the rest of you who are in this group?
Elena, I think that the visual audits, they're very important. And so when the nurse managers go out to the floor to visualize the staff with their infection control practice, for example, catheter care, hand hygiene, cleaning and disinfecting the dialysis station, then you really get a chance to see the variabilities of your staff. You know, are they consistent with doing as the policies at procedures stipulate, or do you see differences in the way they are performing? So actually being out there and actually visualizing the staff, I find that it is very, very important. What is also important also is to try to trend to see if there's a particular staff that you have that, you know, for example, every week or every month when you're doing your audit, that staff is popping up as being not adhering to the policy and procedures, because then that will give you additional information on how to proceed. And then incorporating the findings in QAPI, presenting it, your findings to the QAPI team on a monthly basis also is very important, because it gives the team an opportunity to speak about, you know, other interventions that we can try and how to address the issues that we're finding with the visual audits. So visual audits, I think they're very important in terms of combating or mitigating infections in the dialysis nursing home patients or inpatients.
I couldn't have said it better myself. I think it is true. And the other thing that is important is it allows you to verify anecdotal comments. If a staff person comes to you and say, you know, so-and-so isn't changing their gloves the way they're supposed to, or they're not washing their hands between gloving, that if you kind of just walk around, you know, when you're making rounds or saying hello to patients, you're absolutely correct. You can observe a lot. And bringing it up in QAPI is a confidential way to identify different people that you need to work with more intensively, tools that you can do, like a communication tool, or maybe someone is struggling with readability. And if you go over them visually and one-to-one, it's a lot easier and you get better understanding giving somebody a piece of paper to read. So I think that what you and Marcia both showed about visual audits, I think is excellent. Thank you. Next slide, please. So what you're doing is taking us to the next step, is what we call our Plan, Do, Study, Act. Next slide. So what we did is we took you through an example here that basically it's a test of change model, because what you do is you're doing it right now. You've identified your RCA, you've identified your problem areas. Now what you have to do is you're going to plan, what are you going to do about it? You're going to try your ideas, you're going to observe the results, and then you're going to say, this was good, this changed, the feedback I got here was not very helpful. You know, I need to write it more plain language, I need to do more visuals, I need to cut it back. Nobody has time for 40 minutes this week. I have to figure out a way to do my education in 10 minutes. So all of these steps will take you through the PDSA and do the activities that we've mentioned on these calls. Is you identify your problems, what are you going to do about it, and how are you going to drive success? The one thing that's really important here is that when you're doing a PDSA cycle, remember that you do not have to be licensed to be involved in a PDSA. When you're talking about doing activities, your unlicensed staff spends a great deal of time with your patients. And you can use them to help educate, to help answer questions, because it's almost like a train the trainer. You're educating your staff to know how to answer questions. And you know your staff well enough to know what they can handle and what they can't. There are some things that you may only allow the licensed personnel to do because it's higher level knowledge. And there are others that the best person to do it is the PCT, because they have this incredible relationship with the patient. And then we're also going to talk about using your patient advocates that are actually patients in your clinics that will represent your ideas in the best way possible because they're living it. Next slide, please. So what are the main interventions we'll use? How soon do you put these interventions in place? How do you know your plan is working? What are your unforeseen barriers? And at what point do you include patient and family? So let's break it down. Next slide, please. So what is another main intervention that you will use? We talked about communication. Can someone else mention another intervention besides direct observation, audit tools, and communication tools that could help us in our PDSA? Is anybody willing to share, or do I need to pull out my list? I see you all chuckling. Is that, I think I recognize Marcia's chuckle. How about you? Marcia? I think you might
Sorry,
be on mute.
sorry, Elena, that wasn't me chuckling, by the
But
way.
that's okay. You could help me anyway. You all need
right.
to know, as an insider, Marcia and I actually worked together in Maryland. So it was really cool catching up with her the other day and realized that we had actually worked for the same LDO. And I have a lot of respect for her. She does amazing work.
Oh, thank you.
You're welcome.
So what was your question you were asking?
So what other interventions besides direct audits and communication tools would you use at a PDSA to drive this work?
Well, obviously, we want to get the catheters out. That would actually drive things a long way. So
Yep.
making sure that our process to get patients to the vascular surgeons and their access is placed prior to them coming to us would be a huge help.
And so how are you doing that now with all the restrictions of COVID?
That's my trouble.
Exactly.
We try and do patients while they're in the hospital. So if they're a patient that's in the hospital for a week or so before they come to us, we I don't want to say beg, but we try very hard to get their access placed while they're there, so
Okay.
that that part's already taken care of. That's not always possible, obviously.
Right.
With all of the reopening that's happened here in Western New York, we haven't had too many troubles getting patients in to be evaluated and get that placed. Some appointments have gotten canceled for various reasons, but we are still able to get patients in. It's just taking a little longer.
Okay. So slow and steady wins the race.
Yes.
Okay, next slide, please. So how do you know your plan is working, and how do you identify things that you never even thought could possibly happen and did? So let me mention one, since you all seem to be thinking about it, is one of the things that you know your plan is working is in your QAPI meetings, you're going to look at the numbers. You're actually going to be able to look at your infections. You're going to look at your hospitalizations. Are they being hospitalized for infection? You're going to look at your lab work and see what's happening with the anemia. You're going to look on rounds and see are people needing their ESAs changed, their prescription, are they non-responders? And one of the biggest unforeseen barriers is we thought we had COVID in a bag, and now we have the Delta variant. So we have another thing that's come up that we really weren't predicting. People really thought that by this fall, we'd be in a much better place. Next slide, please. So at what point do you include the family? The one thing is that the sooner the better. One of the things that I've learned in my over 40 years in dialysis is that oftentimes the patient is not the decision maker in the family. It might be the wife, it might be the son, it might be the girlfriend. So the sooner that you can identify who that patient support person is and get them to work with you and with your clinic to help drive change, the better outcomes you're going to have. Multiple studies have shown that people who take an active role in their care do much better and live longer. And I think that that's something that you all see. And one of the things that I think has been the biggest advancement that CMS has done is not just identifying patient engagement, but also family engagement. Next slide. So let's talk about patient and family engagement, because this also is another focus area for CMS. Next slide. So as we said, one of the things that you see when you have patient and family involvement, you have a better quality of life for the patient. You see less anxiety and depression. They have people they can interact with, people they trust. It promotes independence because something simple as a family member knows if you can wash your face. A family member knows if you can wash your access. You know, that ability to do those little things that make you feel independent, that you don't have to be assisted with everything, can be incredibly important to an individual patient. It improves the patient's experience of care. You're not talking over them, you're listening to them, you're giving them a minute, because as they age, they may respond much more slowly. And it also increases what we call a positive outlook in healthcare. They know you care. They know that you're taking the time to listen, because what happens a lot of time in our work, we call it the law of automaticity and body memory. We have put people on, taken people off, gotten their vital signs, read the alarms, do the charting to where we could do it in our sleep. But we're not making cars. We're taking care of people. And we're taking care of people that may have slower response times, whether it comes to getting on the chair, getting on the scale, swallowing their medicines, getting their arm out so you can give their IV meds. And that ability to involve them in their care and involve their family and share information really is very helpful. And they also have found that it results in a reduction of medication errors, not just medication reconciliation, but patients being able to say, now, remember you gave that to me last week. It's something I get every other week. And I'm pretty sure I remember that I got it last week. So, you know, it really does help to involve families, involve patients, so that we become better at what we do. And we don't forget why we're doing what we do. Next slide, please. So we need to integrate patients in our work. It's something that we as a network are passionate about. Facilities have been working on quality improvement activities with patients for the past several years. And so each facility, you all got the email, needs to identify a patient facility representative. And there is lots of ways that you can identify these high achievers. You know, there's always somebody that everybody's talking to, you know, when they're in the clinic, or somebody always sharing a story or a smile or a joke, somebody who's very comfortable talking to other patients, family members that are coming in with the patients and saying hi and asking questions and being active. And so they can help with talking about their own experiences, helping go over information that you hand out. You can invite your patient to patient conferences with a family member, to your QAPI meetings. And I know people worry about issues of confidentiality, but you can carve out the first 10 minutes of your QAPI meeting to invite a family member or a patient to talk about what's going on. So these are just some of the ways that they can help. They can help you do lobby days, make bulletin boards. It's amazing how much artistic talent is out there. Next slide, please. So these are some of the things that patients and families have been identified as activities that they need to participate in for CMS. Patient participation in life planning, patient involvement in QAPI, and promotion of peer mentoring. And they actually have set up an official peer mentoring program because we know that you all do not have the time to set up peer mentoring, pull all the tools together and things, so that the NCC has created an activity around that where there's actually course material, and they get a nice certificate that says that they've completed it and they're able to serve as a mentor to other patients, and it makes a huge difference. I've met several of these individuals and I feel like they're a gold mine of information. Next slide, please. So the other thing is, this is what you got. It's the form. And why this form is important is it's not enough to volunteer. It's enough only with the fact to recognize their joy and their contribution. But legally, we have to have documents. We have to have informed consent. No, it's not a surgical procedure, but what is required by CMS is informed consent, so the patient knows and the facility representative knows that this is what you volunteered for. Do you have any questions? What do you want me to go over with you so that you understand what it is that you're doing? And that there's a confidentiality form because you want to be sure that certain information is not shared. And if something is shared accidentally, even that they know that it can't go beyond you or the QAPI team or you and the physician, whatever. So, this recruitment tool is incredibly important. Next slide, please. So remember how I said that we are really committed at IPRO to get this education to you in the easiest way possible and in the most convenient way possible? Next slide, please. So what has been developed is a computerized learning system. Next slide, please. In this computerized, no, not the next step, back one, please, I'm sorry. So what happens is that this will be a one-stop shop. You all will get a login for your clinic, and some of you may already have it because, we already sent the information out about this. And what is cool is that this is not a confidential system. You'll have one login for your facility. Everybody can use it, the PCT, the social worker, the dietitian, the FA. That what will happen is that any individuals in your clinic can go in and look at quality improvement activities that we send out, patient experience of care activities, giving us feedback on tools, announcements, and things like that. So I did not build into this education today to go over with you how to get into it and what you need to do. You all got the email on it, and I'm going to be reaching out to you guys in the next week or so that we can get you into the system, make sure that you're comfortable playing around in it. And I really suggest that you play around in it at least once a week. It's like learning to use your cell phone. The more you use it, the more you learn about what to do with it. So we're going to go over this, and I think it's something that you guys will really enjoy because you can get into it at your convenience. And that's the biggest thing, I think, that makes this a really cool system. Next slide, please. So next steps. Next slide. The idea here is that we have to work our plan. So you will have not only the opportunity to participate, but the opportunity to be evaluated. As I told you today, CMS is going to follow the activity that you all are involved in, making sure that we let them know how many people have been successful in terms of moving their numbers to the right and, less infections and less transfusions, less incidents of peritonitis, that how many people are using the tools that we got? What are the tools that we have that you all consider successful? What's the feedback that you're getting from the patients? You shared a tool with 11 patients and 6 of them liked it, 2 of them said, it was okay. And the other said, I'm sorry, I think it had too much writing on a page, make it shorter, because we do not want to move things forward into the next cohort and the cohort after that if it doesn't work. So that's the biggest thing that's going to be important. You're going to have knowledge assessments, like for the education on the frail elderly, that 17-minute video, because I want to know what you got out of it. I want to know if you think it's worthwhile. And did you learn what I thought was important for you to walk away with? Because you're not going to remember everything, but any education has key points. And the biggest thing that's important is that we'll have the data will get stronger as we go along. You'll participate in trainings, you'll participate in meetings at a local and a national level. And the biggest thing is, like I told you all before, we're in this together. The idea is to make you successful. Next slide. So this is what will happen. You all know about the NCC and their activities. And as I said, we will be inviting you guys to calls where we will be sharing, the information about what's going on. We'll share best practices. You'll get surveys. They'll be short, sweet, and to the point. They shouldn't take a long time. And if you have questions with the surveys or problems, all you have to do is reach out and somebody will help you. And the biggest thing is, because we can't get into the nursing homes, we have to count on you to help us. We'll be making up one-pagers and tools that you can share with the nursing home staff, that they can hang over the bed, that they can give to families, they can give to patients, because we want to be sure that we're making it easier for you to communicate with them, to educate them, and to drive change. We talked about the patient facility representative. We talked about the IPRO Learn system. We're going to be getting together about that, making sure you guys have what you need, and all of this stuff is stuff that will also help you with your state surveys, because you can show them that you are actively involved in education, interventions, and communication to improve care for the patients in the nursing home. Next slide, please. So we've gone over September, October, we've got work that's assigned. So September, we're finishing the PDCA. We're going to do the frail elderly. We're going to start doing our plan, do, check, act, looking at what it is that, or do act. I was going to say I learned it as a different acronym, but it's the same idea. And then what happens is, again, we're going to make it easy for you. We're going to share materials that we've made up that have already been vetted and tested. And you're going to let us know if we're on the right track. In October, we already have an intervention that we've got for you to do, and you're going to be doing your work. You're going to be available for network call. We'll decide if we're going to do it as an office hours call, or if you need some extra time or you don't want to talk in a group, let me know. We'll figure it out. Next slide. November, what happens? We have another intervention, so you can see we're planning ahead so you all can plan. And then again, look at your numbers, let us know how it's happening. Again, we'll have another network call. Next slide. In December, the biggest thing is we start drawing things to a close for the intensive activity group. You get an opportunity to meet the next cohort that's coming in and do your bragging rights and talk about what together we learned that we did well, what we need to change, give your honest feedback, so that when we go forward with the next cohort, if we need to tweak something, we'll do it. If we need to put something to bed, we'll do it. If we found something that you guys shared with us that is great, we'll steal it. We'll make it part of our work, so that we can give you credit for having a really cool idea that we're able to move forward. And you guys will still be part of this. We'll still keep an eye, and we'll still reach out to make sure that there's no backsliding, that you're still doing the interventions that are mailed forth, but you're not going to have to be talking to us as frequently as you did before. Next slide. So just so you know, this is basically the end. So I actually am not the network QIA lead. As much as Megan and I looked at these slides, that's a mistake. I'm the quality improvement director. So see, this is why I say it takes a village. In IPRO Learn, we're going to work on getting you into the LMS platform. We'll be talking about a first desk ticket, which how you can also use to communicate with us when you need additional support with some of the tools that we send you. Next slide, please. And so the biggest thing, and I really mean this from the bottom of my heart, you took an hour and a half of your time, or an hour of your time, or a little less than an hour and a half, to share, to commit, to spend time talking about what's going on. And I want to thank you all because I know how hard it is out there. I've been a dialysis nurse, I've been a facility administrator, you know, I've been a manager, I've been a clin spec, I get it. You know, I have a daughter who's a social worker. I know how hard the social workers work. And so you know, infection control nurses, I can't thank you enough for your commitment. And I want to take a few minutes, and if any of you guys have any questions or comments, did you find this helpful? I would appreciate it. So can we make sure the lines are open? Can anybody give me some feedback?
So I thought it was very helpful, Elena, because coming into the webinar, I didn't have a good sense of what the expectations are. So now that you have explained, and the slides were very good in really identifying what the expectations are. So thank you for that.
Thank you. Anyone else? Cyril, let me ask you, because I pulled you off the floor for this. Do you think it was helpful?
It's helpful, but you know, all of our dialysis facilities right now struggling with staffing, and we all are on the floor, and you know, especially for seniors, we limit all the calls and all the stuff during these months. So sometimes I am able to attend these calls, sometimes we are in a difficult position to attend all these calls. So we need to be.
I appreciate your honesty, and that's why we will work with you with the IPRO Learn system to try to make this as easy for you and your staff as we can.
Thank you, Elena.
Thank you. And I want to thank you all. And if we have no other comments, I will give you back 25 minutes. And again, this recording will be available that we will share with you so that you can share with your staff and your physician champions so that they know why we're doing this activity, how they can contribute to this activity. And again, thank you for sharing your time and your knowledge with us. We couldn't do it without you. And Megan, thank you very much.
Thank you very much. Bye-bye.
Bye, everyone.